So for pediatrics, 6 questions that you can ask patients at any time. The first one is, are you in pain? Are you eating? Are you drinking? Are you peeing? Are you pooping? And what is your activity level? And I'm really going to stress this last one. The activity level is very important in the pediatric population. And you'll notice that these questions are pretty much the same as questions you might ask adult patients. So these questions are very similar to other rotations, but many pediatric patients can't tell you exactly how they are feeling. Therefore, you should take eating, voiding, and activity level much more seriously in these patients. Okay? So this is a funny meme that I found on Reddit, but it says white blood cells 40,000. CRP 200, large pneumonial changes in X-ray, I sleep. And then too tired to eat or play, real shit. Okay, so this is just really emphasizing the importance of activity level in the pediatric population. One thing I'm also going to recommend is that after watching this video, I would also highly recommend you watch Emma Holliday's pediatrics video, because it has tons of high yield information on there. And she obviously gives a very, very excellent lecture on prepping you for pediatrics. So in terms of my content, I want to talk about first jaundice and stuff that happens right after birth. Okay, so for jaundice after birth with an unconjugated hyperbilirubinemia that occurs between the 2nd and 4th days of life, that is called physiologic jaundice. And you can often see that the bilirubin will go up to 7 to 9 in white or black babies, or up to 10 to 14 in Asian babies. If you see jaundice within the first 24 hours, which is earlier than, the 2nd to 4th time span, or you see a greater than 5 increase in 24 hours, or it persists after 10 days of life, this is what we call non-physiologic jaundice. And there's a lot more concerning things that we need to be on the lookout for if this happens. So what are some of the causes of non-physiologic jaundice? That includes ABO incompatibility, polycythemia, Crigler-Najjar or Gilbert syndrome, sepsis, and biliary atresia. What is a feared complication of severe jaundice? So a patient's jaundice is in the 20s, and you're planning to start phototherapy so you can help more easily excrete some of that bilirubin. But the feared complication you're trying to avoid is kernicterus, which is chronic bilirubin encephalopathy. So it crosses the blood-brain barrier and causes lots of long-term neurologic problems. So what is it called if you have jaundice in the first few days of life due to inadequate breastfeeding, whether that's the mother is not able to have a good enough supply or the baby's having trouble latching on? That's called breastfeeding failure jaundice. And this is to be differentiated from jaundice that occurs around 2 to 3 weeks, which is due to an enzyme that is present in breast milk and actually increases the amount of bilirubin that's absorbed in the GI tract. And that's going to be called breast milk jaundice. And this is due to the beta-glucuronidase enzyme. And the mechanism that you're going to see on your UWorld test and shelf exams is that it's going to be increased enterohepatic circulation of bilirubin. What about if you have a baby with hypertonia and hyperreflexia of their lower extremities? They have motor dysfunction, and when they crawl, they really use their upper extremities more, and they have what's called kind of like a commando crawl appearance. That's a description of cerebral palsy. Another thing that they do is sometimes they'll just pick up the patient and their legs will cross and it'll kind of have like a scissoring appearance, and that's also a potential buzzword for cerebral palsy on your exams. The biggest risk factor for cerebral palsy is important to know, and that's just going to be prematurity. And this is one of the biggest reasons that we give antenatal steroids in premature deliveries. What is a test that all infants less than 28 days old with fever should get? This is a lumbar puncture. Now, there's going to be on your test an infant with a flattened head and an anteriorly displaced ear and forehead and a mass in the sternocleidomastoid. That's a description of torticollis. So if you take a look at this picture here, you get frontal bossing, the ear gets displaced anteriorly, the occipital area gets flattened, and so that's what they're kind of describing in the UWorld stem. The treatment of torticollis is going to be increased tummy time because you're relieving some of that pressure on the back part of their occipital bone. You do passive stretching and physical therapy. What is the differential for a baby who has not yet passed meconium or their first stool? This is going to be meconium ileus versus Hirschsprung disease. Meconium ileus is important to know because it's associated with a very specific disease, and that's going to be cystic fibrosis. And then what is a test that you can get to differentiate between meconium ileus and Hirschsprung disease? That's going to be a contrast enema. And let me go and show you what it's going to look like when you do get that contrast enema. So basically, you shoot up a bunch of contrast that's going to light up when you get an x-ray through the rectum. And then in meconium ileus, you are going to see microcolon. Okay, so everything is just very, very contracted and very small. Whereas with Hirschsprung disease, you're going to see a transition point and a dilated proximal colon with a narrow sigmoid. So it's got two different appearances, and they're going to show you this on the test and ask you to identify whether this is meconium ileus or Hirschsprung disease. What is the gold standard test for diagnosing Hirschsprung disease? That's going to be a rectal suction biopsy. And the mechanism of Hirschsprung disease, very important to know this, is failure of neural crest cell migration. Very common pimp question that you're going to be asked, and very commonly asked on shelf exams as well. And then what is a very common condition that's associated with Hirschsprung disease? Again, important to know. This is going to be Down syndrome. So a lot of patients with Hirschsprung disease are also going to be patients who have Down syndrome. What is a newborn baby that has a fluid swelling that crosses suture lines, and it's just fluid, it's not blood? That's going to be called caput succinatium. A lot of people just say caput because it's kind of hard to say that. And so this is a good graphical depiction of this. It's a fluid swelling that's very kind of superficial on the skull, often happens after delivery, and it does cross suture lines. Differentiate this with a newborn baby with a bruise that does not cross suture lines. That's called a cephalohematoma. And so here you see this is a little bit deeper in the scalp, and it does not cross suture lines. A lot of times, this will be something that reabsorbs slowly over time and actually will increase the bilirubin level of a baby because they're kind of reabsorbing this broken down blood product. And then finally, if you have a newborn baby with blood that does cross the suture lines, this is a little bit more significant. This is called a subgaleal hemorrhage, and you can see the difference here between the cephalohematoma and the subgaleal hemorrhage. It's much larger, it's crossing the suture line, so it's a much more significant bleed. A few more questions for newborn babies. So an initially normal newborn starts to have rapid onset hypotension, cyanosis, and hypoxia that fails to improve with 100% oxygen. This is going to be describing a ductal dependent congenital heart defect. And the reason this is not improving with oxygen is because this is completely a vascular issue. It has nothing to do with, their lungs. And so giving them more oxygen is not going to help the perfusion defect. The treatment for a ductal dependent congenital heart defect is going to be prostaglandin E1, which is used to maintain the patent ductus arteriosus. And then diaphoresis when feeding is a very common buzzword that you should be aware of. And this describes also a congenital heart defect. The next thing that I want to describe to you is a 1-week-old baby that turns blue or has difficulty breathing when they're feeding, and they turn pink when they're crying. This is going to be a description of choanal atresia. And so choanal atresia is when you get this basically blockage in your nose, and this is a unilateral one and bilateral choanal atresia here. And then this shows that the nasal airway is blocked here. And so this is a very common description for choanal atresia, is turning blue when they're feeding. And what is a syndrome of different things you should look for if choanal atresia is found? That's going to be the charge syndrome, which describes coloboma, which is kind of like the iris is abnormal, heart defects, GU anomalies, ear anomalies, and deafness. So charge, that's an important syndrome to know about. Next, let's move on to newborn babies that have lots of vomiting. You end up putting an NG or an OG tube, and you notice that it's curled up on the X-ray. This is going to be a description of esophageal atresia. And what if you have a newborn baby with esophageal atresia and a gas bubble in the stomach? That's going to be describing a tracheo-esophageal fistula, which is very commonly seen with esophageal atresia. So here's a graphical depiction. Esophageal atresia is when basically you have the esophagus coming down and it just ends, right? So when the baby is feeding, it's not going to be able to go down to the stomach, so they're just going to vomit it back up. And that's why the NG tube is going to curl up here too, because it can't go down to the stomach. And then eventually what you really get a lot of the times, 87% of the time, is you're going to have a distal tracheo-esophageal fistula. So air is going to be coming down, and then it's going to go down into the stomach, so you're going to get a large gas bubble in the stomach. So an X-ray appearance is going to be like this, where you put an NG tube, it just curls up in the esophagus like this, and then you notice a very large gas bubble in the stomach, which shows you that there's probably a tracheo-esophageal fistula. What is an acronym for other anomalies that are associated with TEF? So this is basically similar to charge syndrome, but it's anomalies that you see with tracheoesophageal fistula. That's going to be called VACTERL, and that's going to be describing vertebral, anal, cardiothoracic, esophageal, renal, and limb abnormalities. Next, let's talk about bilious versus non-bilious vomiting. So the reason we care about if it's bilious or not is when it's bilious, it tells us that the obstruction is a little bit further downstream than non-bilious vomiting. And bilious vomiting is a little bit more concerning because it suggests that there may be some kind of obstructive process going on. So if you have a baby with bilious or non-bilious vomiting and double bubble sign on x-ray, so this is a very, very classic buzzword that you should know about, this is describing duodenal atresia. So what condition is commonly associated with duodenal atresia? This is just like with Hirschsprung disease, that's going to be Down syndrome. And then what is the mechanism of duodenal atresia? For some reason, they really like this on your board exams. The mechanism of this is failure to recanalize at weeks 8 to 10 gestation, which basically means when you're forming embryologically, things close off and they open up again. But with duodenal atresia, it had a failure to recanalize or open back up. Next, we have a baby with bilious vomiting, and they have an absent jejunum and ileum. And then there's this description of the ileum winding around the vascular stalk. And this is very memorable for me because it was one of the UWorld questions that I had. This is going to be describing distal intestinal atresia, not to be confused with duodenal atresia, okay? So these are different conditions. So the mechanism of distal intestinal atresia is going to be a vascular accident in utero. And this is really often going to be mothers who are hypertensive or they're doing cocaine when, they're pregnant, things like that, which causes a vascular accident to happen while the baby's in the womb. Next, let's talk about a baby with bilious vomiting due to abnormal pancreas development. That's going to be describing annular pancreas. What about projectile vomiting in a firstborn male baby around 1 month old? Very classic description. This is going to be for pyloric stenosis. A physical exam finding of pyloric stenosis is a palpable olive-shaped mass. And next, let's talk about what is the most feared condition if a baby presents with bilious vomiting. So what's the most dangerous thing that you want to rule out? And that's going to be intestinal malrotation, where basically things start twisting around its own mesentery, particularly where the cecum kind of just gets malrotated in the right upper quadrant and everything cuts off its own blood supply. So this is the main thing you need to rule out if patient is presenting with bilious vomiting. What about if you have a young kid that's running around happily, but intermittently gets abdominal pain that causes them to curl into a ball? This is a very classic description. They're very fine. All of a sudden, they get cramping abdominal pain. Then they're running around again, fine again right after that. That's going to be describing intussusception, which is when one of your bowel loops kind of telescopes into the other bowel loop. And then what is a physical exam finding of intussusception? That's going to be a sausage-shaped mass or target sign on ultrasound. And then what is the treatment for intussusception? That's going to be an air enema. So you literally just blow a bunch of air in there and hope that this corrects the problem of the telescoping bowel. And then what is a late complication of intussusception? That's going to be current jelly stool. So this is not contrary to what we kind of learn. We learn this association with current jelly stool, but when current jelly stool occurs, that's basically like your bowel is dying off already. So this is a very late finding of intussusception, and that's going to suggest a need for surgery rather than just treating it with air enema. And then lastly, what are the most common causes of intussusception? This is a very high yield question that you should know. This is going to be basically hyperplastic lymphoid tissue or Peyer's patches, but also fecalith, or basically a poop ball that's causing intussusception. So now I'm just going to throw on some pictures. This is the double bubble sign of duodenal atresia. So you notice how there's the big bubble of the stomach, and then you have this proximal duodenal bubble, and then there's basically just a cutoff point where the duodenum does not further advance. And so that's why you get this double bubble appearance. Next, this is distal intestinal atresia. So you have basically the in utero vascular accident, and then the jejunum just kind of ends. And then you finally get this ileum that's curling around a vascular stalk. So that's the description that we talked about earlier. And so intestinal atresia, it kind of goes over duodenal versus jejunum, and it goes over the different pathophysiology, the different clinical findings, and then the associations. Again, duodenal is associated with Down syndrome. Next, this is a picture of annular pancreas, which shows that the pancreas is basically just wrapping around the duodenum and causing an obstruction like that. So you get bilious vomiting. And then here is a depiction of pyloric stenosis, where in your firstborn male baby, you get a very hypertrophic pyloric muscle, and this causes a blockage and then explosive like projectile vomiting. And then finally, this is the most feared complication. This is going to be intestinal malrotation, where it twists around its own mesenteric stalk, and then you get a cutoff of blood supply to the bowel. And then finally, this is a depiction of intussusception, which is a piece of bowel telescoping into another piece of bowel and causing crampy abdominal pain intermittently. And very commonly, this happens at the ileocecal junction. Next, let's talk about some common genetic abnormalities that you're going to be expected to identify. And this is something that really came up when I was a medical student, and even classic descriptions were kind of things that I missed. And so with this review, I hope it really helps you get these right. Okay, so this is the most classic description, but you got a flat face, protruding tongue, small ears, epicanthal folds, upslanting palpebral fissures, a congenital heart defect, excessive skin on the back of the neck. I basically threw every single buzzword that I could here, but anytime you see any of these, this is going to be describing Down syndrome. And it's really nice to have a graphical depiction because it really helps you kind of, identify this. But upslanting palpebral fissures, basically it shows how the eye is kind of upslanting upwards like that. Epicanthal folds, you actually see this very commonly in normal anatomy of like East Asians. But in patients who you're suspecting of Down syndrome, this is something that you look for. They have small ears, short neck. You see this redundant skin in the back of the neck and just a very flat face overall. And then a couple of other extra findings that I was pimped about and I did not know is that they tend to have a shortened fifth finger. They have a single palmar crease, which is not normal. Normally you have two palmar creases or two major ones. And then you have what's called a sandal gap deformity, where you have a widely separated first and second toe. So these are all things that you should know, especially these hand findings, because I got pimped on that and I did not get that right. So hopefully that'll help you guys get that right. Why must anesthesiologists be cautious when intubating a patient with Down syndrome? This is due to atlantoaxial instability. Next, let's talk about a patient that's described as having a small jaw, which is kind of the big one that I'm going to be pointing out here, as well as the clenched hands with overlapping fingers and rocker bottom feet. That's going to be describing trisomy 18 or Edwards syndrome. In contrast, you're going to have a patient that's described as having a cleft lip or cleft palate, which I think is very pathognomonic for this one, and area of absent skin on the scalp. This is going to be trisomy 13 or Patau syndrome. And so the reason I underlined those specific findings is because there are a lot of overlap findings that you're going to see on both of these patients. So finding the ones that are kind of unique to one versus the other is a little bit more helpful for you, especially when you're identifying this on a test. Okay. So here is some graphical depictions. This one on the left is 18 or Edwards syndrome, and this one on the right is 13 or Patau syndrome. So notice the micrognathia or the small jaw is very kind of classic for Edwards syndrome, and then the clenched hands with overlapping fingers here. These are the two parts that I kind of want you to really remember the most. And then for Patau syndrome, the cutis aplasia or the lack of skin on the scalp in certain areas, and then the cleft lip and cleft palate, which is really easily identifiable, which really differentiates it from Edwards syndrome. Next, let's talk about a tall male with gynecomastia and hypogonadism. This is a description of Klinefelter syndrome or XXY. And then we have a short female with a webbed neck, a shield chest, widely spaced nipples, and streak ovaries. This is describing Turner syndrome or XO. So a picture here, you'll see that this is Klinefelter's on the left with tall stature. They have some breast development or gynecomastia, and they have small gonads or testicular atrophy. And then for Turner syndrome, you have short female, webbed neck, shield chest, widely spaced nipples, and rudimentary ovaries. So these are two classic descriptions that you also need to be able to identify, both on your test and on possible PIMP questions. What about if you have a male with intellectual disability, a very broad forehead, a long face, and enlarged testicles? This is a description of Fragile X syndrome. And you'll see here on the left is a typical male, and then a male with Fragile X syndrome. Notice how long and big their face is, and notice how they have macroorchidism or enlarged testicles. These are kind of the classic descriptions of a patient with Fragile X syndrome, in addition to the intellectual disability. Next, we have a description of a newborn with a cleft lip, a heart murmur, muscle spasms, and seizures. And this is describing DeGeorge syndrome or a 22q11 deletion. And the reason they have muscle spasms and seizures is because they have profound hypocalcemia. What about if you have a patient with infertility, recurrent ear infections, and heart sounds on the right side of the body instead of on the left side of the body? This is describing Cartaginer syndrome or primary ciliary dyskinesia. And so this is really important because the heart sounds on the right side of the body is very classic for dextrocardia, which you see sometimes in primary ciliary dyskinesia. And the infertility is because the sperm are not motile, so they can't really be fertile. Next, we have a young boy with intellectual disability, seizures, and acne-like papules on the face. This is a description of tuberous sclerosis. And the skin findings of tuberous sclerosis are going to be ash leaf spots and shagreen patches. And here's a picture of that. Here are some ash leaf spots and shagreen patches noted here. What about if a patient has inappropriate laughter? They're very happy all the time. They're having seizures, ataxia, intellectual disability, and they're described as a happy puppet. That's called Angelman syndrome. And then next you have an obese patient who really can't control their eating. They have some mild intellectual disability as well and hypogonadism. That's called Prader-Willi syndrome. Next is if you have a 1 to 4 year old girl who starts to regress in their developmental milestones. They have ataxia, seizures, and hand wringing. This is a very classic description for Rett syndrome. And then what about if you have a patient with recurrent kidney stones and they also have concomitant peptic ulcer disease or Zollinger-Ellison syndrome? So how can you connect recurrent kidney stones with peptic ulcer disease? That's going to be a description of multiple endocrine neoplasia type 1. So these patients have hyperparathyroidism, so they're going to have hypercalcemia, and then they have peptic ulcer disease because it's very noted to have an incident of pancreatic tumors, especially things like gastrinomas, which can cause Zollinger-Ellison syndrome. So that's how you make the connection there. And this is something that I was asked on my board exams, and it's an interesting connection to make. Next, you have a description of a 3-year-old with fever, conjunctivitis, erythema of the oral mucosa, and enlarged cervical lymph nodes. That is a description of Kawasaki disease. And Kawasaki disease is very easy to identify when you know what you're looking for, but sometimes when you just hear the symptoms by themselves, you may not identify it. But remember, the mnemonic for remembering the symptoms of Kawasaki disease is crash and burn. So C is for conjunctivitis, R is for rash, A is for adenopathy or enlarged lymph nodes, S is for strawberry tongue, H is for erythema of the hands and feet, and then burn is for fever. So these are all the symptoms that you'll see with Kawasaki disease. Next, I'm going to go over the steroid synthesis pathway because actually on the board exams, they really like to nail this home. And so it's really important to get this pathway down. And there's some easy ways to simplify it. And I hope with this video, I can help simplify it a little bit for you to keep it a little bit more straight in your head. But it's always nice to bring up this picture of the actual steroid synthesis pathway so you know which enzymes are being affected. So first, let's talk about a patient that's presenting with hypotension. They also have hyponatremia, hyperkalemia, and they have early virilization in boys or ambiguous genitalia in girls. So this is basically all of this stuff is showing you that they have a deficiency in aldosterone. So because aldosterone helps with our blood pressure, it helps excrete potassium, helps retain sodium. So they have low aldosterone. And then here, this is all telling you that there's increased testosterone, right? So what would cause low aldosterone and high testosterone? Well, what if we knocked out 21 hydroxylase, then all of this steroid synthesis pathway is going to be shunted over to making testosterone, and we're going to be completely unable to make aldosterone. So this is going to be a 21 alpha hydroxylase deficiency. So hopefully that makes sense. You know, we're blocking both of these pathways here. There's no cortisol, there's no aldosterone, there's only testosterone. There's actually multiple phenotypes of 21 hydroxylase deficiency. It's a little bit more complicated than just, that one thing. There's salt wasting, non-salt wasting, and non-classic. So you should be aware of that. But I think the overall thing is to just be aware that they're going to have low blood pressure, these electrolyte abnormalities due to lack of aldosterone, and they're going to have these sexual findings because of increased testosterone. All right, now let's talk about a girl who's presenting with hypertension, and they have no menarche, and they have hypokalemia, okay? So hypertension and hypokalemia tells us that the aldosterone is high, and then the lack of menarche means that they're not having any, sex hormones. So what's going to block all these sex hormones? That's going to be if you blocked here, 17 alpha hydroxylase, right? Because everything is going to be shunted down here to aldosterone, and you're going to get no sex hormone production. So this is describing a 17 alpha hydroxylase deficiency. Next, we're going to have hypertension and increased testosterone. This is going to be actually an 11 beta hydroxylase deficiency. So that's knocking out right here. The reason you have hypertension is because this deoxycorticosterone and 11-deoxycortisol have some weak mineralocorticoid effects. So they actually will help your blood pressure. And then you're still going to be shunting a lot of things to the sex hormone pathway. And so these are going to be increased. So this is why you have high blood pressure and you have increased testosterone. So a nice mnemonic mnemonic that I found when I was looking on Google Images. So there's this mnemonic CAT. So A stands for aldosterone, and then T stands for testosterone. So for 21 hydroxylase deficiency, you have low aldosterone and high testosterone. 17 alpha hydroxylase, you have high aldosterone and low testosterone. And then 11 beta hydroxylase, you have high of both. So this is a really easy way to remember these 3 commonly tested questions that you're going to be asked. When I say that the shelf exams and the board exams are going to be really nailing on these kind of like sex hormone deficiencies and other problems, I am not under exaggerating. So we're going to continue a little bit more here. So we have a 46XY patient who appears female, even though they have the genotype of a male. And so they have breast development. This is very important. They do have breast development and they have no virilization. This is going to be a description of androgen insensitivity syndrome. So the reason this patient is able to have breast development is because they completely have a non-functional androgen receptor. Normally, androgen blocks breast development. So if your androgen receptor is completely not functional, then this genotypically male patient is actually going to have breast development. In contrast, if we have this genotypically male patient who appears female with no breast development, this tells us that there is some functional androgen receptor that is blocking breast development. And they also have virilization, which means that they are responding a little bit to some of the androgens that they do have. So you'll see a little bit of clitoromegaly in this kind of patient. And this is going to be due to 5-alpha reductase deficiency. So these patients still have testosterone and they still have response to those androgens, but they just don't have the strong version of testosterone known as dihydrotestosterone or DHT. So they appear female, they don't get breast development because of the low level of androgens, and they do have some virilization. Lastly, we have a genotypically female patient who appears female but has no breast development and they have virilization. So this is going to be a patient with aromatase deficiency. So aromatase is right here in this pathway. This is what converts testosterone over to estrogen and estradiol. So the reason they have no breast development is because they don't have estrogen, and they have virilization because they have this excess testosterone that's lying around, which is going to give them clitoromegaly and, facial hirsutism, stuff like that. So very important to know the difference between all of these conditions. I would say this is a very high yield slide. So definitely know the difference between 21, 17, and 11 hydroxylase deficiency, as well as androgen insensitivity syndrome, 5-alpha reductase, and aromatase deficiency. Now let's talk about some milestones that patients should be facing, because very commonly in the outpatient setting, your main thing is going to be ensuring that these patients are meeting their developmental milestones and that they are getting their appropriate immunizations and vaccinations. So this is basically all of outpatient pediatrics. So what is the age at which newborns should have doubled their birth weight? That should be 6 months. What is the age at which newborns should have tripled their birth weight? That should be at 1 year. What is the age at which a baby should have a social smile and start to coo? That's at 2 months. The age at which they should be able to roll over should be at 4 months. Being able to sit upright is at 6 months. The age at which primitive reflexes disappear, this is very, very high yield for your board exams. These tend to disappear around 6 months. However, there is one primitive reflex that's normal to persist up to 2 years of age, and that's going to be the Babinski reflex. I'm going to say this is very, very high yield because I've been asked countless times on my board exams about this, and I got it wrong multiple times because I didn't realize that the Babinski reflex was going to be lasting up to 2 years of age. So it's actually normal for them to continue to have that reflex, and it's not a sign of some upper motor neuron damage if there's a 2-year-old with a Babinski reflex. What is the age at which a baby should be able to do a pincer grasp? That's at 1 year. The age at which they should be able to stand, 1 year. Be able to run is at 18 months. Walking up and down the stairs 1 foot at a time is at 2 years. Normal vocabulary range for a 2-year-old is 200 words. Now, what if you have a baby whose vocabulary is not up to par? They're not able to do 50 words at age 2. Then the main thing you need to do is a hearing evaluation, because maybe they're not able to have that good vocabulary because they simply have poor hearing. This is a very nice overview of all the developmental milestones. And I basically went over kind of the most important ones that I think you should know. But there's various other ones you should know as well, such as, drawing things, drawing circles, crosses, building cubes, towers, and stuff like that. Next, let's talk about vaccinations. So definitely know this vaccination chart and when vaccinations are going to be due. I'm going to say the most high yield ones that you really should know is that the MMR and the varicella vaccines are going to be due at age 1 year and age 4 years. So those are definitely important to know. And those are all live vaccines. So our vaccine schedules adjusted for premature kids. Say somebody's born at 32 weeks instead of being born at term at 37 weeks. Do you adjust the vaccine schedule? The answer is no. You just go based off their chronological age. Is a short seizure after a tetanus vaccine a contraindication to getting the next dose? The answer to that is no. And then what are the true contraindications to vaccines? Because this is very, very common that patients are going to be asking you about this. And this is going to definitely come up on your board exams. But the only true contraindications to vaccines are going to be a severe egg allergy to the flu vaccine, in which case you get a egg preservative-free flu vaccine, anaphylaxis, and unstable neurodisorders. So if somebody has a fever or a seizure or some kind of like localized response to a vaccine, it's not a contraindication for them receiving that vaccine in the future, even though it's like a seizure, which seems very concerning. It's actually not a contraindication. Next, let's talk about a pathognomonic eye finding for abusive head trauma in a baby. This is going to be a retinal hemorrhage, very high yield for you to know because this is going to come up on your board exams a lot. What does a burn with spared flexural creases suggest? That's an intentional scald injury. So this is what kind of it happens is basically they get angry at the baby and they put them in really hot water. And then you see how here it only hits these areas. And so when the baby comes out, they're actually going to have areas that were not in contact with the hot water. And so you get spared flexural creases, which is a sign of intentional scald injury. If it was an unintentional scald injury, you would basically see splashes everywhere and it would just be like a really random distribution. It would not have this characteristic appearance. What are cafe au lait spots with a coast of California appearance? This describes neurofibromatosis. And then cafe au lait spots with a coast of Maine appearance describes McCune-Albright syndrome, which is a problem with growth hormone. And so McCune-Albright syndrome, you can see it's a very irregular border. So this is a coast of Maine. Whereas with neurofibromatosis, the cafe au lait spots are very smooth bordered. You may get a question about a baby who's only being fed goat milk and then they begin to have failure to thrive. This is going to be describing folate deficiency and megaloblastic anemia. This is a very interesting one to know about. The other thing to know about is that patients who are only fed breast milk sometimes can get iron deficiency anemia because there's actually not enough iron in breast milk sometimes. But otherwise, breast milk is by far and away the best type of feeding for your baby. Next, you have a 14-year-old boy who's always below 5% in height. Their parents are tall and were late bloomers. And this is called a constitutional growth delay. Important to know this because this is basically just saying they're going to reach normal adult height, but they just kind of grow a little bit slower and it kind of runs in the family. And you'll see that their bone age is less than their real age, which suggests that they have a lot more room to grow. Next, you have a 14-year-old boy who's always been below 5% in height and their parents are both short. This is going to be familial short stature. Bone age is going to equal their real age, which suggests that they are reaching their full growth potential at this point already. And then next, we have a 14-year-old kid who was previously 50% for height, but in the past years is down to 5%. This is much more concerning. This is going to be called pathologic short stature. So check for many different causes that could be causing this: hypopituitarism, craniopharyngioma, hypothyroid, or Turner's. Now you have a young kid with a febrile illness and they have a seizure lasting less than 10 minutes. This is called a simple febrile seizure. Know that this is not something that's very serious, and this actually does happen quite commonly. And patients who have had febrile seizures in the past are more at risk of having febrile seizures again in the future. Is diagnostic testing warranted for a simple febrile seizure? The answer is no, just treat symptomatically. And how long can patients have postictal confusion with simple febrile seizure? That's about 10 minutes. If they have longer confusion or altered mental status, then they probably should get an LP to check for meningitis. And then what about if you have a well-appearing infant with a family history of eczema who starts to have painless bloody stools after starting to eat like a solid diet? That's due to food protein allergy, and they need to do basically an elimination diet to make sure they aren't eating things that are triggering this. Next, I want to talk a lot about knee and hip pain, which is going to be very common in the pediatric field. So let's say you have an adolescent kid who's going through their growth spurt. They run and they jump a lot, and now they're having knee pain. This is going to be called Osgood-Schlatter disease, and this is due to damage to the secondary ossification center in the proximal tibial tubercle. If you have the description of an obese adolescent kid who starts to have hip pain and possibly knee pain, and then the x-ray shows a displaced femoral head, that's a description of slipped capitis femoral epiphysis, or SCFE, and this is basically the ice cream falling off the ice cream cone description. So you can see this is the ice cream here, or the femoral head, and it's falling off the ice cream cone. So this is a classic description and x-ray that you're going to see on your board exams. What about if you have a 5 to 7-year-old boy with a painless limp who now starts to get severe thigh pain? That's called Legg-Calvé-Perthes disease, and this is idiopathic avascular necrosis of the femoral head. What about a young kid with a recent flu-like illness who is now limping, and then you get an x-ray which shows an effusion and you also get labs that show elevated ESR? That's called transient synovitis. This is very high yield because it's very common. The treatment is bed rest and NSAIDs. What about if you have a young kid who starts to develop hip pain just like the guy above, but they also have elevated ESR and they're ill appearing and they're unable to bear weight? Then this is much more serious. This is going to be septic arthritis, and the treatment is arthrocentesis and antibiotics. So very important to be able to differentiate transient synovitis with septic arthritis. What is an antibiotic class that you should avoid in young kids? That's going to be tetracyclines due to the permanent staining of teeth. And usually I believe it's up to 8 years of age where you want to avoid tetracyclines. What is the main differential for posterior fossa tumors in a kid? That's going to be a pilocytic astrocytoma versus a medulloblastoma. So this is a little bit less concerning, and this is a little bit more dangerous. So here is a description of what you'll see on your test. You'll see a pilocytic astrocytoma. It's like calcified. It's very well defined. Whereas a medulloblastoma, it's a very, very ill-defined, very difficult to see kind of density there. And then you also can have an association with hydrocephalus. What is the best next step in evaluation of a patient with early secondary sexual development? That's bone age evaluation. So you'll see here for precocious puberty, you want to check that bone age first. So if they have advanced bone age, then you check their FSH and LH, and you can tell if it's peripheral or central precocious puberty. And if they have normal bone age, then this is actually just kind of premature breast development or premature pubic hair development, and it's not actually a problem with their hormones. This is a common pimp question that you may be asked, but are loud or soft murmurs more concerning in a child? That's going to be a soft murmur, because if you have a loud murmur, that actually suggests that the defect is very narrow, so that the blood going through the ventricular septal defect, for example, is going to go very, very quickly, and it's going to be very loud. But hemodynamically, it's very insignificant because it is very small of a defect. Whereas if you have a soft murmur, this suggests that you actually have a very large defect, so you don't have as fast of a gradient of blood going over to the other side, so it's more quiet. But it's much more hemodynamically impactful, because you have a lot more blood that's being shunted from one side to the other. And you're going to be doing this a ton in your outpatient well child visits. So this is called the Ortolani-Bartlau maneuver. And basically you do this procedure and you test for any clunks or sounds that you hear while doing this to see if they have any hip dysplasia. And remember, breech presentation from your OBGYN rotation is going to be one of the major risk factors for having developmental hip dysplasia. What if a patient has inspiratory stridor at 4 to 8 months? It's worse when they lie flat on their back, but when they lie on their stomach, it actually gets better. That's called laryngomalacia. For some reason, they really like to ask about this, so I would definitely know about this. This is actually the most common cause of stridor in infants. So the diagnosis of laryngomalacia is done through laryngoscopy, and the treatment of it is just spontaneous resolution, but oftentimes they have concurrent GERD, and so that should be treated. If you have a description of an infant with postprandial regurgitation after eating, but they're otherwise asymptomatic, this is what we call a happy spitter, and this is not something that needs to be treated. It's very, very important to know what the most common bacteria is that causes acute otitis media, because you will definitely be pimped on this, and that's going to be strep pneumo, and the other two common organisms are going to be H. flu and M. catarrhalis. The treatment for acute otitis media is high-dose amoxicillin for 10 days. And so these are very important to know, because so many patients, when they come in the pediatric population, this is going to be one of the most common complaints that you're going to be treating. The definition of recurrent acute otitis media is important to know, and that's going to be greater than 3 episodes in 6 months or greater than 4 episodes in 1 year. And this is important to know because this is an indication for tympanostomy tubes. What is the reason why kids over age 2 don't necessarily need antibiotics right away for otitis media? This is also high yield and important to know. But this is because their eustachian tubes actually have a steeper angle and they actually drain better on their own. So a lot of times this can just be kind of self-resolving. So if you take a look here, this is an infant on the left, and then you have an older kid on the right. So the eustachian tube here is very flat. It's very easy for fluid to collect in there and then bacteria to grow. Whereas in the older kid, it's a lot more steep, so it drains a lot better and it prevents the occurrence of infection. What if a patient has otitis media and now they have an anteriorly rotated ear and pain over their mastoid bone? This is mastoiditis, so very important to check for these things because this is an indication for surgery. What if they have an ear infection with swelling of their ear canal and pain with moving the external part of their ear? That's called acute otitis externa or swimmer's ear. And the treatment for that is going to be topical fluoroquinolones. What is a test that all kids with a UTI and age less than 2 years old should get? That's going to be a renal and bladder ultrasound to check for vesicoureteral reflux. The next step in management for a kid with a red and swollen joint, we kind of went over this already, but that's arthrocentesis to check if they have septic joint. What is criteria that you can be used to evaluate the likelihood of strep throat? That's called the Centaur criteria. Very important to know because we also use this in the adolescent and adult population. And the 4 components of Centaur criteria is actually an acronym. So it's cough absent, exudates on their tonsils, enlarged nodes, and a temperature. So Centaur, the CENT, is basically all the components of the mnemonic. And basically you calculate this Centaur criteria score, and then you decide whether you need to treat, for strep throat or not. Notice how if they're age 3 to 14 years, they get an additional point. If they're age greater than 44 years, they actually lose a point. What is a mnemonic for questions to ask an adolescent after their parent leaves the room? So in all these visits with adolescents, there should always be a point where you ask the parent to leave the room so you can ask them some questions in private. And the mnemonic is going to be HEADS, which stands for home. How are things going at home? Education. How are you doing in school? Activities. What are some extracurricular things you're doing or how are you keeping yourself occupied? Drugs. And then sex or suicide. And so here's the mnemonic depicted here. Finally, if a patient has a seal bark cough and this chest x-ray where you see this sign, so what is this? The prudent people among you are going to identify this as the steeple sign, and that's going to be describing croup. And the treatment for that is going to be a corticosteroid, usually 1 dose of dexamethasone, and nebulized racemic epinephrine if severe. And this is something that you should know about because it comes up on the board exams a lot. All right, so that was a long one. Thank you so much for staying until the end if you're still here, and I hope it was useful for you. Those were a lot of the pimp questions and board questions that I got when I was on my pediatrics rotation, and so I'm really confident and I really feel like this could help you get honors in your rotation. If it did help you, please leave a comment down below, consider liking the video, and also check out the playlist for the rest of my medical school guides. Consider subscribing to the channel to get more content like this in the future, and thank you so much. I'll see you in the next one. Peace.